have a few more people coming into the room today, but I want to officially kick us off. My name is Lindsay Orchowski. I'm a co-director of the Research to Practice and Policy Core of the Injury Control COBRA at Rhode Island Hospital. And I am absolutely delighted today to introduce Dr. Jennifer Johnson, who is going to be speaking on implementation science and community engaged research in injury prevention. And Dr. Jennifer Johnson is a clinical psychologist. She conducts NIH-funded implementation and effectiveness trials of mental health and substance use intervention for high-risk women, including perinatal women and justice-involved populations. And after spending more than a decade as a faculty member at Brown University, Dr. Johnson transitioned to Michigan State in 2015 and has built an academically vibrant and socially responsive team of community engaged scientists. I'll also mention that Dr. Johnson is the PI currently of 5 NIH grants, as well as the submitting PI and recipient of a P50 award from NIMH focused on establishing this National Center for Health and Justice Integration for Suicide Prevention. And I am absolutely delighted to have her share her knowledge with us here today. So with that, Dr. Johnson, take it away.
Thank you so much. And it's wonderful to see you again and just wonderful to continue the Rhode Island connections. So I'm going to talk about today, if you are familiar with this, the right side of the translational spectrum. So clinical efficacy, which is how do things work under tightly controlled conditions, effectiveness, dissemination, implementation, and translation to communities. So before I started, I wanted to give a little bit of the background of how I got where I am. So I was at Brown. I was actually a postdoc at Brown a while ago. And I did a clinical psychology PhD. I came to Brown. And as a postdoc, I was doing work on intervention development in the women's prison in the Rhode Island Department of Corrections, addressing co-occurring mental health and substance use disorders. But that was a formative experience for me because as I looked around in Rhode Island, which has a fairly low incarceration rate and is better funded than many places, I wondered, why am I the only PhD level provider around here other than the head of all behavioral health services? At the time I was there, I believe there were only 12 social worker slots for the entire state Department of Corrections, several of which were not filled. And I thought, well, why? And, you know, as I talked to people working around me, they were substance use counselors. They were making $13 an hour. They were, you know, with a bachelor's, if that. And I thought, well, don't the wardens know what's going on here? So I would talk to the wardens, but the wardens realized that more than half of the people there had mental health problems and 2/3 had addiction. And I thought, well, you know, why aren't there more clinicians here? And then when I went to subcontract to the DOC, I realized I couldn't change a line item in the DOC budget without an act of the state legislature. Well, then I thought, well, don't the legislators know? And some do and some don't, but ultimately they were answerable to the voters. And it's a little bit of a nuanced message that providing adequate health care for people involved in the criminal legal system doesn't mean we're condoning crime. It's not what you put on a campaign ad. If you have 15 seconds, you say, I'm so-and-so, I'm tough on crime, right? And so pretty soon I realized, coming from this intervention development space, that you could have all the interventions in the world, but if the system was fundamentally broken and there were no providers, it didn't matter. So I started doing much more work in implementation science, community engaged research, and ended up here in Flint, which I will tell you a little bit about in a minute. So I know that many of you know about implementation science, but for those of you for whom this is new, I love Jeffrey Curran's, has this article called Implementation Science Made Too Simple. And in this case, the intervention or practice is the thing. Effectiveness research looks at whether the thing works. That's what I was doing. Implementation research looks at how best to help people or places do the thing. So for example, even get providers, right? Implementation strategies are the things we do to try to help people or places do the thing. And the main implementation outcomes are how much and how well they do the thing. So again, very simple. It becomes about helping agencies and people and places do the evidence-based thing. So I also wanted to give a quick primer on community engaged research. And we are honored that actually the first author of this publication is on our in our audience today, Dr. Kent Key. I love this as I put the article reference down there as a way to really think about what community engagement means. So, these things go on along a spectrum of, between the researchers and people involved in the target communities, how power and control is shared, how ownership is shared, resource sharing, money, benefit, influence. These are all equity indicators. And it can be everything from over here at the left is, no community involvement, where the researcher says we had no contact with the community and the community says we didn't even know about this project, through, the community might be aware of it, to the researchers met with us, to they gave us opportunities to participate, to we told them what questions we needed answers for, to community-based participatory researches, we participated in all aspects equitably, and then community-driven or led is the community fully owns the research and the researchers support them. And so, different places along this continuum can be appropriate in different situations. But I think I wanted to show this because I think it's a nice conceptualization and to challenge folks to maybe try a step or two to the right of where they've tried before, because it's an interesting, enriching experience. All right, so I wanted to give you a quick primer on the US criminal justice system, which we will be talking about. Basically, I think people think, oh, people go to prison and they stay there forever. Well, that's not really what happens. This is a model used by SAMHSA, and these intercepts are places where behavioral health or other interventions can intervene to change the course of health or the course of legal involvement for someone. So, over here on the left, 911 calls, there's 240 million of those a year in the US. Police contacts, that's 53 million. Being arrested and detained in jail, typically 3 to 7 days, you may or may not be charged, right? That's 11 million. And then all this. So overall, though, the system is touching a lot of people in the US every year. And as we talked about before, there are a lot of risk factors. The thing here I mainly want to point out is that the suicide mortality rates, the US population versus incarcerated, that's been recognized more. But what people don't realize is that there is a lot of death by suicide in following incarceration. People are released, they have access to lethal means again. When they got arrested, things weren't going well. Typically you get arrested when your life is spiraling out of control. And it's, this post period back in the community is a very high risk period. So, why? Well, there's a lot of reasons. Pretty much every suicide risk factor is elevated in people who are interacting with the criminal legal system. And this is not yet published, but we did some analysis that suggested that more than 20% of adults in the US who die by suicide spent at least one night in jail during the prior 12 months. Meaning that, like I said, the problem in suicide prevention is that you are trying to find who's at risk during the moment they're at risk. It's a needle in a haystack problem. But unfortunately, police contact in jail is a good way to find the needle in the haystack because you're finding people at risk, but you're also finding them in the moment they're in crisis. If brief suicide prevention interventions are as effective in jails as they are in emergency departments, implementing them, in jail or the community after jail could prevent, more than 10% of all US suicides, adult suicide. So, what is usual care in jails? And again, prisons, state and federal prisons are one system, right? Jails are run by counties or municipalities. And so there are more than 3,000 in the US. This is where people come when they're arrested. Most aren't sentenced. They might be released on bond. They may or may not be charged. And if sentenced, they stay there less than a year. So this is the in and out, right? So what's usual care for suicide prevention? Well, people who are considered to be at risk are put on watch, and people hate it. Basically, I think the jails want to do what they can to keep people safe, but people don't like it. You have to wear this quilt thing that you can't hurt yourself with. You don't get privacy. In some jails, they won't give you a fork, so you have to eat something they call patty. If the staff determine the suicide risk goes down while you're in the jail, they'll just release you to general population. If you get released to the community while they think you're acutely suicidal, they might ask somebody to take you to the emergency department, but really you're kind of released out into the world. And is this because jails are trying to give bad services? No, it's not. They do their best to screen and triage, but a mid-sized jail could admit 13,000 people a year. They might have one social worker. So it's 50, 60 people a day. People are psychotic, manic, high when they come in. And so they're just doing the best they can. The system really is not set up for good suicide care, suicide prevention care. So, but this isn't really different because many systems serving people most at risk are low resource systems, or they are not treatment systems at all, right? Police, first responders, fire, these aren't supposed to be treatment systems, but these are the systems that interact with people overdosing, at risk for suicide, partner violence, et cetera. So actually, I'll tell you the story. So the National Institute of Mental Health came to Van Miller when I was still in Rhode Island, and said, we're looking for ways to try to prevent suicide among people not well connected at care who are at risk for suicide. And we think some of them are in the justice system. And Van kind of said, I do suicide prevention. I don't really want to deal with that. So he talked to Lauren Weinstock, who talked to me, and she did suicide prevention research. And I did work on, improving services for people involved in the criminal legal system. So Lauren and I joined forces, and in 2015, the SPIRIT study was funded. It was an 800-person randomized trial that took place here in Genesee County in Flint, Michigan, and in Rhode Island. It was actually the first randomized trial of any intervention for suicide risk reduction following release from jail. And I think, honestly, in any justice-involved population, it's a field that's neglected in a lot of ways. In 2012, I published the largest randomized trial to date of depression treatment in an incarcerated population. It was only 50 people. So, the research lies behind. But anyway, we had money to do this clinical trial. And the goal was, to use jail to identify risk, but then like I said, most people are pretrial, they go back out to the community. So our goal was to use that vulnerable moment to prevent suicide in the community in the year after they left. So like I said, it's a critical moment to engage and intervene. It considers challenges and coordination of care for mental health and substance use between jail and the community. Part of the challenge here is people are at most risk right when they leave. But right when they leave, they don't have, the jail providers are no longer allowed to follow them, but they haven't connected in the community yet. And that handoff is really risky. And some programs will work by bringing community providers into the jail who can see the person once they're released, which is what we did in this case. So we took community mental health clinicians who we recruited, who would come into the jail. Our research assistants would recruit during the day in the jail. And if they had somebody, they had the counselors scheduled to come in the evening, who would come and deliver the safety planning intervention by Stanley and Brown. It's an evidence-based suicide prevention intervention for emergency departments. Like I said, it had never been tested in the jail. And then the community clinician, when the person was released, would follow up by phone 3 or 4 times in the community, try to help problem solve any suicide issues that came up, connect the person to crisis services, connect them to other services if needed. It's not treatment, but it's a kind of an adjunctive thing to keep someone safe and alive until they can get their feet under them and do some other things. So, you know, we have stakeholder partners, well, we had, which I'll talk more about. But, you know, we intentionally had people or the organizations as stakeholders that would eventually implement this in the community if found effective. So Genesee County Jail, Rhode Island Department of Corrections, and community mental health in both communities. So I'm actually not going to tell you the results of that trial because that's not the point. But it was feasible, it was acceptable. I think NIMH was worried that an intervention like this wouldn't work among a primarily substance using population. We did not find that at all. And as a matter of fact, you know, it's sad, but when the standard care is so low, almost anything you do makes a difference. And so, you know, even the resource guides we gave people in the control condition, sometimes people would ask for more to give them to their friends. So I'll just say the trial went well, published results are forthcoming. But my point here is that, you know, evidence, it's not like the world doesn't have evidence suicide risk screening measures. It's not like there aren't suicide prevention interventions. It's not like there aren't electronic health records, but they're not being used in most of these settings. And this is a resources and capacity problem, not a motivation problem. And I'll tell you a little bit about that in a minute. I pasted this, this figure in here just to show briefly, again, you know, effectiveness is does the thing work, implementation is how do we help people in places do the thing. The outcomes there are, you know, was it adopted? Is it appropriate? How much did it cost? Penetration is what % of the providers are using it. Was it sustained, right? Versus, you know, did it work? So I wanted to talk a little bit about, you know, when I set up about this public opinion that the legislators are answerable to the public. Well, I learned this, you know, I learned it as a postdoc to some extent, but when we were doing Spirit, I was reminded of it again. So, you know, when Spirit was funded, NIMH was excited, National Institute of Justice was excited. It was a collaborative project. I had just come to Flint, Michigan in January of 2015. I was actually the first research faculty member here. So I was in an empty building. It was the first big grant awarded in Flint. It brought in all these millions of dollars to Flint. Isn't this exciting and isn't this wonderful? So we did some press on this article, on this grant, right? And you should never read the comments on your articles, but I did. So let me show you some of the things that they said. A total waste of money. Take the money and put it toward preventing all the suicides by veterans. I don't care about prisoners. I care about veterans. Priorities. Productive members of society pay to spend millions to study the drugs of society. What a country. So there's so much wrong with this, right? But just even factually, there's so many things wrong with it. They're not prisoners. A lot of them won't even be charged with a crime. If charged, they might not be convicted. 6% of them are veterans. Honestly, if you talk to people, if you know anyone who's been arrested, they're in touch with the system. If you've ever had the police come to your house, you're in touch with the system. I have family members who have been arrested. I have, and if you think about your friends, I had a friend, bless her heart, who threw a pot down the stairs at her ex-boyfriend and she was arrested, right? That's who this is. But like I said, we're coming up against this knee-jerk reaction. And I'll tell you, it's interesting. I was at, let's see, I don't want to identify people. I'll just say I was in an institution and my chair introduced me to the new dean and said, oh, this is Dr. Johnson. She does work on mental health and substance use for people involved in the justice system. And I just saw the dean's face sort of register like that has nothing to do with me. And I know, like, he's a medical school dean. I know that they care about people, but it's just so people get othered so quickly. And so this is always the sort of knee-jerk reaction that we're saying that we think crime is great, that we think, we shouldn't ever lock anyone away. I don't know what they think, but this is part of what we deal with. And this is one of the implementation science challenges. But, you get some of this, we saw some of this kind of like gut level reaction with COVID vaccines or health equity or social determinants, right? A lot of what people react to just doesn't really reflect what's happening, but it's a gut level reaction. So that's one of the implementation targets, right? So public policy. So whoever knew that I would get into that. And I have colleagues here at MSU who we have a top 3 in the country communications department, academic department of communications, whose whole thing is how do you talk to the masses and communicate messages, right? So that becomes an important and interesting part of what you do, which I never thought when I was training in graduate school to be a clinical psychologist. Another potential implementation target, like I said, so after we did this pilot study in 2012, while I was still at Brown, we led the first randomized trial of any treatment, medication, or psychotherapy for major depression in an incarcerated population. Had a cost effectiveness analysis. For those of you who know implementation science, it was a hybrid type 1, where hybrid means you're just blending effectiveness outcomes and implementation outcomes. So we looked at, did the thing work? But then we also looked at a little bit, what would it take to, implement the thing widely? So, we found this was IPT, interpersonal psychotherapy for major depression, had a really nice effect. Folks were very severely depressed despite being on a lot of medications and other things. But what was really interesting when we looked at the implementation outcomes, well, like I said, it's, we were using master's and bachelor's level counselors. Like I said, I had learned before that if you need a licensed clinician, you might not be able to do it. So we were doing some task shifting to bachelor's level folks. And, the treatment reduced depressive symptoms, hopelessness, PTSD, and increased rates of remission relative to prison treatment as usual. But we did our cost analysis. 72% of the cost of the intervention was for provider training and supervision. So a lot of this was, some of it was the time to do it. A lot of it was the fact that the providers working in the system make so little. So even our time, on the university side to provide supervision was relatively costly. And, I've had jails and prisons reach out to me since and say, hey, we would love to have some training in this. And we said, okay. But even for them to take all their staff off for a one-time training takes some doing for them, but you can't train a psychotherapy in a one-time training. And they just, even to take the time for them off the floor to do that is hard. So, this is another potential implementation target, is how do you create some sort of effective, but much more scalable training when a system just really can't spare its one clinician or two clinicians, right, to go do something else for a while. So again, this is an example of an implementation question. So the summary to this point, because I'm going to start talking about different but related studies, are that, like many things, suicide, overdose, substance use, mental health, HIV, partner violence, a whole host of things, people at risk are served in these low resource or non-treatment systems. And for the most part, the systems aren't using evidence-based practices, not because they don't want to. When we did the study, this was the most motivated provider sample I've ever seen, but they just didn't have the people, they didn't have the resources, they didn't have the time, they didn't have anything. The capacity is the problem. And as implementation scientists and researchers, capacity is one of the things that we deal with. And especially in community engaged research, building capacity is one of the things that we deal with. And I personally think this is the fastest way to save lives. I think that 70% of health problems could be changed through better health policy, which involves rules and fundings, both like state, big P policy, or local policy, budgets, staffing, whatnot. So again, before I go on, I wanted to review, I love this article. It's from 2012, 10 key ingredients for implementation science research grant proposals, right? So the first is the care gap or quality gap. You have to make a case that there's a thing and people aren't doing the thing the way they should be. You have to have the thing, the evidence-based treatment, to be implemented. a conceptual model and a justification for it. You have to show that somebody in the world cares about this, that it's not just you and the university trying to get people to do the thing, but that they care and they see a need for the thing. You know, you need a implementation strategy, which is how do you get the places to do the thing so that you have some experience with all of it, and to show that there's some potential, at least, for policy leverage or funding environment to support the change. So using those steps, I wanted to talk about another implementation trial. This one is currently ongoing. If you want the protocol, it's there, published in Implementation Science in 2021. And this is a study Faye Taxman from George Mason University and I are co-leading. And, you know, my bread and butter is the randomized trial, and you can do randomized implementation studies. I do them all the time. But, you know, when you're working more with these bigger systems and in the real world, I've also become more adventurous with research design. So this one is quasi-experimental. So again, implementation science reminder, study on how best to do the thing, evidence-based practice policy or procedure is the thing, and mechanisms are, if A is your implementation approach, in other words, how you're going to try to get people or places to do the thing, and C is do they do it, E is what's in the middle. So like, how does whatever you're trying to do get them to do the thing? And this is that kind of study that focuses on mechanisms. So it's interesting. So the design is this. So we have, there's a national initiative led by the Council of State Governments, the National Association of Counties, and the American Psychiatric Association Foundation to try to reduce the number of people with mental illness in jails, especially those that don't need to be there, that are just there because the police couldn't figure out where else to take them. And so this, and that that initiative has enrolled maybe 500 counties across the US. At the time we started this, it was about 475. So we have those 475 counties. We matched 475 matched comparison counties, and we're following them at 3 time points over time and trying to look at the mechanisms of policy change. And we do that by, we have surveys and some qualitative interviews of the administrators of community mental health, community substance use services, the jails, and probation in all of these counties. And the questions are really, how do counties work across these different sectors to provide a seamless system of care? Because that really is the problem here. And people have known it for decades. It's just how to solve it is a challenge. Is how, you know, if somebody is coming from community mental health, but then they show up at the jail, but then they miss their community mental health appointment, does community mental health drop them? And how do they, you know, just how do we connect people? And, does stepping up an implementation intervention improve the number of evidence-based practices used, the number of people served using an evidence-based practices, and resources like money and staff for evidence-based practices, and if so, how? And that's the mechanisms question. So this is, I guess, a little complicated, but I wanted to show it to you. So stepping up, like I said, it's an implementation approach, and their approach basically says, they ask the counties, okay, convene a team, and the team should have representatives, like I said, from community mental health, community substance use, jail, and probation all together, and they should meet at least monthly. Then identify a screening tool and use it across all the systems. And they wanted them to try to come up with like 4 metrics. They gave them, one is like, how many people with serious mental illness go into the jail every year? How many are connected to care? And you would think that that is an easy question, but it's actually not. In these systems, it's hard. They're not really set up to do this, right? And then they want stepping up wants the counties to set up the screening system and then try to do things, but track its effects on the number of people with serious mental illness in the jail, how long they stay, et cetera. Our sort of idea, the mechanisms we're looking at are, do counties use interagency teams? Are they functioning well? Are they doing this performance monitoring, which is the seeing if what they're doing makes things better? Are they working together across the agencies or not? Do they see eye to eye? And, how much is the system integrated? And then we're looking at the implementation outcomes. So I just wanted to give you this study is only in its second or third year, but I wanted to give you some ideas of the things we're finding, which have been interesting, and again, show the sort of things you can get in a big implementation trial. So we did a big survey, and one of our co-Is, Dr. Ramazani, found that I thought was really interesting about the policy landscape is that lower behavioral health care service accessibility, like, providers and cost, actually predicted a higher per capita jail incarceration rate in counties, but violent crime didn't. Right, which was a super interesting finding, because it says that the size of your jail doesn't relate to the amount of violent crime. It relates to a lack of behavioral health services in the community, right? Which just goes to show that these systems really go together. A project I'm leading helped to identify what even are the mental health evidence-based practices for this group. Those had not been identified before. I'm about to submit this paper, but basically went through what's the evidence for all these things and what is the care quality gap. So here's some different things that are evidence-based and the percent of counties nationally that have this present in the county. So for example, Medicaid eligibility continuity is a way to make sure that if people are in jail for long enough that their Medicaid gets turned off, that it gets turned back on when they get out. That's about 29% of the counties nationally. So again, this is speaking to that care quality gap, like what things do we need to get out in the world and where? This is complicated, but I'll just use this first one as an example. So, we looked at relationship building. These are different ways that agencies use to form relationships with other agencies within their county. And because these aren't published yet, I had to blind them, but we do see that it kind of looks like one of these groups of counties, uses more relationship building strategies than others, especially, shared definitions here, having a shared definition of things like what even is mental illness, what is recidivism, so we can measure it and talk about it. One set of counties is more likely to use them than the other. So, one of the questions that we ask is, so these are some of the things we answer in implementation science, right? But going back to the community engagement, in this case, our community really is these agency leaders. Those are our stakeholders. That's who we're researching. So we wanted to have some benefit for them. So one of the things we did, most of them can't get money for their time in a survey. They're not allowed to legally. But we had a long community engaged process of trying to find out what they wanted to know, based on survey information, and how to try to make these reports readable and understandable so that they got something out of it. And so if anyone in the county answered the survey, we would send back sort of, like here, this programs and policies, the pink check is you have this, and then the blue box is what % of counties have it. And so anyway, my point here is trying to make it worth people's time and find something so that your participants have actual benefit from what you're doing. So, the ultimate goal here is to try to have, it's to use an ongoing natural experiment to identify mechanisms that might work across policy change efforts to improve services. So for example, if we find that it's really use and functioning of interagency teams that makes things better, maybe that's something that we can pull out and use in a different intervention or in a different setting. Because the mechanisms may be generalizable. So that is a full-on implementation trial. It's not effectiveness, it's not anything. It's just implementation. How do people, places, counties start doing the things that they need to do? So I wanted to give you an example of community partnered research and implementation science. This is the National Center for Health and Justice Integration for Suicide Prevention, the one that was just funded in August, I think. And it's 3 PIs, me, Brian Amadani from Henry Ford, and Lauren Weinstock from there in Rhode Island. And so, all right, so take a step back. So like I said, you saw it in spirit, like I was talking about, there's this huge problem in suicide prevention, which is how do you find people at risk? I said, okay, justice system, we can solve that problem because this justice contact is kind of a marker for risk. But then there's the problem of, okay, we identify someone at risk, but the jail just releases them back out into the world, and how do you connect them to care? Like that's a 40 or 50-year problem in any kind of treatment, HIV, anything for justice involved populations, because everybody knows they need to connect, but these are systems, both community organizations and the jail organizations, that don't have a lot of extra people. And it takes somebody to say, oh, okay, Mr. So-and-so, you have this appointment here. Like just even doing that is hard because there are no resources. So in the course of this Stepping Up study I was just talking about, we talked to a Medicaid managed care organization in Ohio, and they had done something genius. And this is their, I'm using their figure. So let's take Ohio, for example. Ohio has 80 something counties, 88, I think. There is a jail in most or all of those counties. There are also several health systems in these counties, right? And because the jails may not, most of them are on electronic health records now, not all of them, but they all use different things. It's honestly a little bit janky, because it's low budget, right? It's people who do the best they can with what they have. But you could and potentially, come up with some sort of data linkage between a jail and a community health system. But if you've done that, you've solved it once. And there's 3,000 jails in the US, and who knows how many thousand health systems, right? So it really is problematic. So what CareSource did, and their Medicaid managed care organization that covers Ohio and some other states, is that biomedical informatics have proceeded to the point that you can pull names out of unstructured text data. So just like the newspaper, for example, or anything. And so it turns out that medical records are covered by HIPAA, privacy, but who is arrested and released is actually public data in most places. So what CareSource did is they found a way to sort of just get, the jail booking and release records wherever they were published. And because they're out there in the world, they could read them in automatically, using advanced AI techniques now. And then they would crosswalk that against their subscriber list every day and see, if anyone of their subscribers had been booked into or released from jail. And, this may sound like a super easy thing, but I just want to emphasize, like, this is a huge change, because for 50 years, we've been trying to have more case managers and more things. And it used to be, when I started, it was someone from community mental health, like going over and looking through paper records every day. And, so the fact that all these things are out there in the world and can just be automatically read in from 88 jails across the state and then crosswalked against your subscriber list, this is huge. And when they said this, I immediately, my brain went, you guys have solved this problem we've been dealing with for 50 years, because you can collect this information from everywhere. And because it lives on the CareSource side, it's not HIPAA protected, right? Because they're reading in the arrest information, not giving out the health information. So they found that of their 800,000 Medicaid subscribers in Ohio in a year, at least, I think it's 43,000 went through jail at least once. So that's about 5%, some a few times, including, interestingly to me, 2,300 pregnant people. So when I saw this, the lights went off, and I thought, you guys have the missing piece here. So Lauren and I had been working together, and we looped in Brian Amadani from Henry Ford. And the piece he brought in is he works with the Mental Health Research Network, and he has ways of pulling both suicide risk and likely suicide attempts out of Medicaid claims data, right? So all of a sudden, we have a way to walk in the jail, the booking and release data, with the fact that that person's a subscriber, with the fact that they might be at risk for suicide or have made a suicide attempt. So all of the projects sort of make use of this, but at different places along this continuum. And I'm especially proud of the center. So for those of you who do research, NIMH is very fond of these R34s, these very small grants. Personally, I hate them. I really hate them. I've done a lot of them, but I just think they set you up because they want to see some good result, but of an underpowered pilot trial, I'm sorry, it's random. Like once in Rhode Island, I proved that psychoeducation cured PTSD. Like that, it's just not true, right? The results really don't mean anything. But then to get an R01, they want it to mean, anyway, I don't like them. So one of the things we were able to do at the center, which is set up to have like 1 R01 size projects and 3 R34 size projects, is every single one of the projects is fully powered because we're focusing the implementation science piece on scale up and scalability, right? So like this project 2, I'm working with Sarah Arias right now who's at Brown at Butler, and we're using CareSource's program. And the study is like 1 year, there's 43,000 people of their subscribers they identify going through jail. We're randomizing half of them to get caring contacts. So if you're familiar, it's just a note. It's an evidence-based suicide prevention, but it's a fairly low touch. It's just a note that says we care about you. If you need anything, give us a call. And then we're also using 12 large behavioral health agencies there and identifying. Now the CareSource can identify people who've been through the jail, let the community providers know, like, hey, somebody showed up in the jail and was just released that you've seen in the last 6 months, maybe reach out to them, see if they need anything, and then can further through the claims data say, this person seems to have had a couple suicide attempts in the last bit, you really maybe should reach out, right? So these are all big scalable projects in different states. One's in Massachusetts, one's in Ohio, one's in Michigan, one's in Minnesota, that make use of this. And again, are trying to do these big things for relatively low cost at scale. And that's the part I'm most excited about, because you can find a solution, but like I said, the system doesn't have any resources. So you have to be able to do something with very few resources, a lot of people, a lot of needs. And I think maybe because of CareSource, maybe we found it. I mean, we'll see. So with the investigators, I guess I just wanted to call them out. We're all over. These folks, the pink folks are at Brown, Barbara Stanley's at Columbia. These folks are at Harvard. These folks are at Henry Ford. We're here at MSU. These guys are at CareSource. So again, it's a big project with a lot of people from all over. But more than that, I wanted to show you this community engaged piece, which is that, since coming to Flint, which I'll talk about in a minute, I'm really committed. I really believe that the more you can engage, whether you call them your end users, the stakeholders, the people you're developing the thing for, the better what you will be doing is. So we have, for the center, more than 100 consortium partners, everything from lived experience to policy people, people who are formerly incarcerated, the Manchester Fire Department, all of these different people. And let me show you how I was able to weave them into the center. So, they're partnered, all the center projects and all the center activities from conceiving to disseminating are partnered. We have quarterly all partner meetings, more than that. Every project that starts out has a think tank at the beginning where we invite all the center investigators and the partners together to talk through the project, anything else we should think about, how would this be scaled, how would this look in real life, what are the real world things we need to think about. Our calls for center pilot projects, we have a process where we get feedback from all the partners about what should be in the call, like what do we need to be asking for in terms of research. They will help with review, be available to assist with development of proposals. Our training component includes visits and tours of partner institutions, matchmaking. Our website isn't totally up yet, but we're going to help match partners to researchers who can address their questions, and help match partners with trainees who can help them with evaluations or whatever they need in exchange for credit. We incorporated the partners into the evaluation. So just really made a point to involve them. And my time is running out. So basically our dissemination strategy is also exciting. We relied on my colleague, Jim Deering here at MSU, who, like I said, is this communication scholar, right? And comes at implementation or dissemination science. And the idea here is that there's this theory that if you have policy entrepreneurs who kind of live in these spaces between, say, policy and practice, or practice and research, or suicide and justice, or justice and health, right? That these people are especially valuable in getting word about something out to the world. And so the center will be the first time. I mean, this is the theory, right? People all think this happens, but this will be the first time we're actually going to do sociometric analysis among our partners and then leverage that to get the word out to where we need to about center results. So I'm also excited about that. And I also wanted to say that, you know, I fully believe that the more the partners are involved, the more results will be useful, scalable, sustainable. And, you know, to the extent, like I showed you before, development of interagency teams or work groups across kinds of agencies is an implementation strategy in this space. Even just convening the center and having people talk to each other, we're hoping can help sort of advance that nationally and just get people together working across all of these issues. So, and that is a formal implementation strategy. So I'm really excited about the center. So in terms of equity indicators, I will talk about quickly. Credit matters a lot. We are working right now for all of our partners to come up with sort of an electronic badge or electronic something that they can use to say, hey, we are officially a partner. We're doing all of this to give them credit and acknowledgement for what's happening. I think I've published with community partners before. I think that they're in the authorship list and where they're in the authorship list matters. I've had projects, and actually we have people on the call who've been on these projects that have used community partners as qualitative coders, as analysts, as interpreters of data with training. Folks can do a lot. And actually, I'm going to brag. One of our Flint community partners was just elected as the president-elect of the American Public Health Association. She is the first community person ever to be elected, and actually the first person without an advanced degree ever to be elected. And you might think that without the degree means, you might make assumptions about that, but let me just say that that is not true. She, here in Flint, her name is Ella Green Mountain, and she runs our Flint Community Ethics Review Board, which is sort of like an IRB, but more about what are the benefits of this research to the community, and are the benefits equitably shared in the community? Like, she is a rock star. Flint and Detroit were some of the birthplaces, well, they were the birthplaces of community-based participatory research. I'm really blessed to work with some of the community side partners who either were there or are in that tradition. So anyway, so representation on teams, I have in grants said this a lot. So for example, here, this is literally in the center application. It says 100% of center PIs, 86% of project and core PIs, 76% of methods core members, and 68% of center key personnel are women and or racial or ethnic minorities. So I'll put that in the grant and I'll build my team to really look like that. And then the other equity sort of thing I've put in grants before is I have a maternal mortality disparities project now where we literally say, you know, a third of the money from this grant or half the money from this grant is subcontracted to our partners. So these are all things you can put. So I'm going to stop talking in just a minute. Like I said, I was the founding faculty member of MSU's Division of Public Health. I came here because MSU had done this really interesting thing where they had, in building a Department of Public Health here, had actually spent 3 years reaching out to the community saying, what are the public health needs here? Who should we hire? What should they focus on? And they were half of the search committee that hired me. And when they showed up to my job talk and half the people there were community members, and they told me, you know, we've identified that mental health and substance use are needs here. They said in different words, but I heard, you know, we need intervention and implementation research, especially on, you know, how to keep things sustained. Please come here. That feels really different. And I think, I don't know how to explain this. I came to an empty building, right? With not a lot of infrastructure here, not a lot of other things, but a real commitment to and belief that this partnered process was the way to go. And we wanted to build in partnership with the community. And the short story is that in the 7 years I've been here, we've hired more people, but we've had more than $100 million worth of federal funding. In fact, NCHATS, the grant that just got funded, was put it over 100 million. And we, you know, I think that the point is there's a lot of capacity here. There's a lot of need, but there's a lot of capacity. And I'm not sure that everyone believed that this thing could work in the sense of like, oh, we might do some good, but could it work from a grant funding perspective? And by the way, people told us that the faculty need to look like the community. This is a little bit old, but you can kind of see that they do. And this is the point I want to get to, that I said once to one of our associate deans, we're the only academic unit in the country that's built in full partnership with those we seek to serve. And his exact words were, who cares? And here's why, who cares? Like, how else do we know what their needs are? Participation leads to ownership, leads to capacity, leads to sustained programs in progress. It multiplies impact. In our county, we have 400,000 people. So we have 400,000 ideas for solutions rather than the 17 faculty. And we attract great faculty for the opportunity to do something that matters. So I guess that my take home and my mantra is that, we're succeeding. We are doing warm and fuzzy good work, but we're bringing in the grant dollars and the publications and all the things. And we're doing that because we partnered with our partners, not in spite of it. And I guess I will stop there and take questions.
Thank you so much, Dr. Jennifer Johnson. It is a pleasure to hear you speak. I'm going to facilitate some questions from folks, and there are many things I could ask you, but I'll open it up to our audience for questions. So folks can maybe thinking about their question. I can start with one. I think it's really amazing to hear about this work in the program that you've built. It's really a model for doing community engaged work. And I love your challenge for all of us to think about moving one step closer to in our work in community engagement, bridging off of Dr. Kent Key's work. So, what are some of your recommendations for how to do that? Thinking about, the work that you're doing on this scale may feel out of reach for some folks who are new to dissemination implementation research, or maybe new to community engaged research. So for folks who are really just dipping their toe in, what would be some of your recommendations for how to start thinking about doing that?
Yeah, well, so I would get Dr. Key's article and read it. Like, I really love it. I think it's a good primer, but and to be fair, I had done some engaged things in Rhode Island, but all this sort of, I would say, semi-crazy things I've tried since coming here are things I learned from my partners here, right? So everybody starts somewhere. I think it's to think about, who do you hope to benefit from the thing you're doing? Is it the providers? Is it people with a certain condition? Is it the family members? Is it a community? And then how can you find representatives from that group and bring them around to the researcher side a little bit? It's almost like breaking the fourth wall in theater or something. So I did just a little qualitative study about needs of women in Flint, but I asked my partners, what questions should we ask? And then I would ask everyone we talked to, are there other questions we should ask, and add them, right? Can they help you interpret your data? Can they, this is a little more radical, but we've had centers here, and we're putting another one where we have an academic and a community PI on every project. Just of all the things that you're doing, how can you, is there any piece of it that the other folks can do? And I don't know, like Dr. Key actually and Ms. Evans are they're the ones I learned from. So I don't know if you have any suggestions, like how do you dip your toe in? I think you just try it.
Are you asking me?
Or? Yeah, I'm asking you.
Okay.
If you have a suggestion.
Well, here's the thing, and this is a good question, Lindsay, because we've had a lot of researchers, a couple for example, Dr. Woody Neighbors, who traditionally did, traditional types of research, but when he came to Flint, he wanted to do more of a community engaged type. And for him, he felt like it was a learning curve. I think it's really starting to have conversations with community, doing like what Jennifer did when she came here. She heard what the community saw the needs were, and then engaged community from the onset of that particular idea. As we were thinking about the research design, as we were thinking about the research questions, those things. And I think that as you build relationships with community members, you kind of find out that a lot of times people use the term community member and people think that that means like not educated in a way or don't know things. And oftentimes these are retired, like Marjorie Evans on here, she's a clinical MSW, and she worked in the hospital system. So oftentimes community members have similar degrees to what we have, and many of them have also worked with data sets and stuff. And so I think if you kind of do an examination of who your community partners are, you'll find out that there are some skill sets that you probably just overlooked or never thought that community partners had. And I think as you build those relationships, you will not only find out that you will have like collaborators within the community, but then those community members oftentimes are mentoring other community members to kind of get those skill sets. So you kind of have this kind of pipeline of community members who are being research ready, if you will. But again, it's all about really taking a true inventory of who your community partners are, what levels of expertise they bring to the table. They're not just for recruitment. They are not just for recruitment. I repeat, they are not just for recruitment. So.
Yeah. And I'll say, so when I got here, I mean, I had the benefit of having some sort of pre-made partners, but you can just find them. But I asked them, like, what books should I read? What should I learn about? So they taught me about Flint. They taught me about racial equity. They taught me about CDPR. I taught them about implementation science, and we go to conferences together, and, you learn from each other, and then you both become better at all of it. I see Mr. Evans has a hand. Can I call on him?
Yes. I really wanted to ask you a question for the benefit of the community. What would you say would be a message to the community in terms of dissemination and implementation science, and how the community can effectively get involved and actually have an impact for good for the community?
But that's a big question. I guess I would say, so it's hard. So here, what I want to say is find someone that does implementation research, reach out, and they should be happy to hear from you. But that's sort of hard to do, right? I know our community members in Flint know how to go to NIH Reporter or just Google implementation science in the local universities. I think, one of the things we want to do in Flint is do better at that matchmaking. But I think I don't know a good way to do that other than Google, and I don't think that's especially effective. But I guess like the academic partners, I just would encourage everybody to just try. I've cold called people before and they've been lovely to me. Of course, I've cold called people before and they've ignored me, but.
Well, I want to close out our time today and thank everyone for this fantastic discussion, for the questions, and Dr. Johnson for this really amazing talk. Thank you so much, everyone, for your time today, and for spending some time to learn about implementation and dissemination and community engagement, because it's absolutely vital for making this world that we live in a better, safer, and more equitable place. So thank you all for being here. Take care, everyone.
Thanks for having me, Lindsay.
Thank you so much.